Welcome everyone. We are just waiting for some of the participants to come to leave the waiting room, since the secretariat is right now accepting their entrance. We have roughly 500, 300 people registered for this event. We know by experience that due to their schedules and to our workload, sometimes it's difficult to attend the sessions, even if you are registered to them and if you are really interested in attending them. So probably won't get as many participants, but I'm sure that once are will actually enjoy this webinar organized by FIP with the title Understanding and Managing Headaches in the Community, Therapeutic Approaches and Advancements in the European Region. FIP has followed this policy of doing some presentations or some webinars in certain regional areas of the globe due to the timetables and the time zones. Sometimes it's difficult to attend the session when it's not actually comfortable in our time zone. So FIP is dividing the presentations and the webinars in several sessions, so that all pharmacies worldwide have the opportunity to attend these events. And I'll start just presenting myself. My name is Luís Lourenço. I'm a community pharmacist from Portugal. I work on a daily basis in a community pharmacy. I'm also involved in the Portuguese National Society and also with the community pharmacy section of FIP. And I felt really honored to be invited to moderate this event, not only because I have a very interesting panel of participants, not only participants, but also speakers, but also on my daily practice. And probably most of you, if you are community pharmacists or you're working in an assistance area, probably will hear a lot of symptoms and complaints from our patients saying that they're having headaches. So it's a hot topic, definitely. So it's important to keep up to date. So what's going on this area? So it's good to be here and to be able to be part of this event. I'd like to take this opportunity as well to make some announcements that are written here. They are self-explanatory. So the webinar will be recorded. Would also be available later on to all FIP members. And again, you have a question box where you can make your questions. You can write down your questions. At the end, you'll see later on with the program that we'll have time for some Q&A, and which is not, some things are not mentioned here, but I like to stress out. First is that we have simultaneous translations in 3 languages besides the regional one in English. That will be in Hungarian, Spanish, and Czech language. You can choose one of these languages if it suits better. If you go to the bottom right part of your Zoom panel and choose the language that suits you best. So roughly we have 80% of the presentations translated, while the other 20 will be in English, because the materials were produced in English. It's also important to stress out that you as a participant will receive a certificate of attendance to this webinar in the next couple of days. The secretariat at the end of the webinar will just take care of that, so no worries. And if you haven't received it, just wait a few more days, because you'll certainly get it on your email. And after this announcement, I would like to thank Sanofi because she has been, the organization has been kindly to support not only the webinar, especially the participation of Professor Goatsby. He was one of the speakers. I will share some of his expertise later on. And so FIP would like to stress out this important participation and involvement and Sanofi. And when you come to the program on this event, you'll see this, I hope, short presentation introduction. And I would like to emphasize that the first 2 speakers, Professor Peter Goatsby and Professor Takayuki Kumamoto, were not able to attend the conference live, but they were kind enough just to prepare a recorded video, which will be broadcast, and that will take us, the first part of our panelist presentation. And later on, we'll have Dr. Luminita Constantine, focusing on regional approaches to headache self-care, leading non-prescription medicines. And at the end, my dear colleague and friend, Dr. Charles Rossing, focusing on pharmacists' role in supporting self-care of headache, especially on the European region. And as mentioned previously, we will have roughly 50 minutes for Q&As. If we don't have time just to answer all your questions, I've been informed that the secretary will pick up your questions, and later on, the panelists will be kind enough just to send you some words to clarify what you have just put down on the Q&A. And at the end, I'll just make a small wrap up and conclusions, and we finish our webinar. So just to keep in mind our learning objectives for today, very much self-explanatory: provide insights on the therapeutic approaches and advancements used in the management of headaches. We know that science is always evolving. Understand the role of non-prescription medicine as a tool in headache self-care. As a pharmacist and as a community pharmacist, of course, you can need to process prescriptions, but you have a wealth of weapons that you can use, mostly with non-prescription medicines, to deal with this healthcare issue. And at the end, identify the role of pharmacists in supporting the self-care of headache through a regional lens. And with no further ado, I'll just move forward with the presentation of Professor Peter Goadsby. As I mentioned previously, you won't be able to participate live, but we have the privilege to have a video that was recorded. So Professor Peter is a professor in neurology at King's College in London, and amongst other occupation that he has the opportunity to share his expertise in different positions. And he's also a professor of neurology at Department of Neurology, University of California, Los Angeles, and he's an honorary consultant neurologist at the Hospital for Sick Children, Great Ormond Street, London. I will now just give the floor to Professor Peter, not live, but in video. Thank you.
Hello, my name is Peter Goadsby, and I'd like to thank the International Pharmaceutical Federation for asking me to speak at these series of meetings about 21st century headache and the way headache is impacting well-being and quality of life. I'm a neurologist and I'm interested in headache disorders. One of the realizations of some work I've been doing with colleagues in the last year and a half to 2 years is that a large number of people, perhaps the largest group of people with headache disorders, don't actually see doctors. And to be simple, we've referred to this as non-doctor treated headache. So on the left, if you look at the population of people who actually seek medical care, who are treated by doctors, about 10% only end up with a neurologist. About 20% of patients end up with a primary care doctor. However, at least 50% of patients with a primary headache disorder self-treat. This is the non-doctor population. It varies a little bit between countries, and I've been working with colleagues, as you can see, from the UK, France, Germany, Brazil, Japan, and Australia. Broadly speaking, very clearly the largest group do not see doctors. In particular, tension-type headache is overwhelmingly treated without consulting a physician. Where does the pharmacist fit in all of this? Well, migraine itself, commonest disabling form of headache, has been stable at the very top, in the top 10 of the leading causes of years lost disability over the last 30 years. What is notable is an increase in the analgesic market and an increase in medication overuse headache, as you can see, from the 23rd most common to the 20th most common disorder in 2015. Pharmacists have a really important role here in providing advice to patients on the use of over-the-counter medicines for pain management, particularly in headache, and advice about the misuse or overuse of those medicines. We can help patients understand what's happening by helping them collect their own information, helping them keep a record, and using analgesics optimally. Now, from real-world data we've collected using the Migraine Buddy app, it's clear that most patients with headache, or indeed with migraine, will have up to 4 attacks per month. As you see, the vast majority will have less than 2 or between 2 and 4, and the very smaller group which come to see headache specialists and neurologists are those that have many more attacks a month. Certainly, our clinics are full of patients with more than 10 attacks per month. Now, patients report in their diaries missed work, social activity, and family time. They report being slower in what they do, slowed up at work. They report difficulties with sleep and difficulties with concentration, impacts in their daily life. For the management of tension type headache and for migraine, it's important to be aware of what's available, and particularly for tension type headache, given most of the management is going to be done outside the physician sphere. We know from the evidence, nice report, review that Ashina and colleagues published this year, that aspirin and acetaminophen, in parentheses paracetamol, or caffeine combinations or non-steroidal anti-inflammatories are the top options for the treatment of an attack of tension type headache. For prevention, lifestyle modification, acupuncture has a role, and tricyclics such as amitriptyline, other medicines, mirtazapine, venlafaxine, as preventives if they need to go on and see a physician. You'll see the distribution is rather similar throughout the world, with about 85%, 86% of patients all over using a non-steroidal, about 70% paracetamol, acetaminophen, and about 50% aspirin, with a little bit of regional variation. Remarkably, in the 21st century, of those with a primary headache disorder, 50% self-treat, and only 20% see a primary care physician. Remember that migraine is the most common disabling primary headache disorder. Lifestyle things are important. Sleep disturbance facilitates headache and often can be associated with cognitive dysfunction. We're obtaining robust real-world evidence from e-diaries, population-based. Most of the patients in these diaries have less than 4 attacks a month, and thus primary headache disorders can often be well managed by pharmacists. There's an enormous amount of good to be done. I'd encourage you all to do it. Thank you.
So we finished the presentation from Professor Peter. Thank you very much. FIP has already addressed a few years to Peter for his for this presentation, and now we move forward with the second speaker for this event. So we have the recorded presentation for Professor Takuya Kumamoto from Japan, focusing on therapeutic approaches and advancements in headache management. Professor Takuya is a professor in the Department of Synthetic Organic Chemistry, Graduate School of Biomedical Health Science, Hiroshima University. He has been involved with FIP for many years now. He was previously the chair of the FIP Board of Pharmaceutical Science, BPS, a special interest group on drug design and discovery, and is currently the chair of the FIP Special Interest Group SIG on new medicines. And he also became a FIP fellow in 2017. And we no further ado, we move forward with the presentation from Mr. Professor Takuya.
Hello everyone, I am Takuya Kumamoto from FIP BPS New Medicine SIG and Hiroshima University, Japan. Today, I will talk about therapeutic approaches and advancement in headache management. According to the International Classification of the Headache Disorder, migraine and the tension type headache, a main part of the 21st century headache, were recognized into primary headaches, which caused by their headaches by themselves. Other headaches associated with other factors, such as injury, vascular or non-vascular disorder, infections, other medicines and its withdrawal are categorized into the secondary headaches. Usually, the secondary headaches become an emergent case, and if you can observe the patient with a sudden and usual headaches or a high fever or change of their mind states. Immediate consultation of the doctor will be recommended. Here lists the medicine used for the headaches, including prescribed medicines. The list of some information in this talk were collected from the guideline of the chronic headaches published by Japanese Society of Neurology and Japanese Headache Society and translated in English and published on the web. For prevention use, calcium channel blockers, beta blockers, S inhibitor, ARB, anti-epilepsy, and antidepressant are used. For the acute therapy, NSAIDs, acetaminophen, ergotamine, and antiemetics are used. Triptans are also used for the acute therapy. The chemical structure is related to serotonin, and its mode of action was at first assumed to cover the shortage of serotonin. However, recent research suggests that the triptan works to binding its receptor on the trigeminal nerve to control the release of the neuropeptide. Safety of the triptans was suspected for the patient with cardiovascular risk factors because of the vasoconstriction activity. Towards this issue, recently new type of the selective serotonin 1F receptor agonist were approved. As shown in chemical structure, it was different structure from those of serotonin or triptans, and so the selectivity is expected on its vasoconstrictions. Regarding the neuropeptide named CGRP, it was reported to be released from trigeminal nerve and to bind CGRP receptors on the brain blood vessels to induce the neurologic inflammatory developing to the migraine. Towards this issue, CGRP itself and its receptor become targets of the drug discovery, and their monoclonal antibody which binds to CGRP itself and the CGRP receptor were developed to inhibit the functions of CGRP, and they are recently approved for the acute and prevention use. Small molecular CGRP receptor antagonists, so-called GEPANs, were also approved for the acute therapy. For the treatment of the tension-type headache, NSAIDs, caffeine, antidepressant, and muscle relaxants are used. For OTC, single drugs of the acetaminophen, NSAIDs such as aspirin like ibuprofen are used. Loxoflofen is approved as OTC in Japan. As a combination product, aspirin, acetaminophen, or both combined with caffeine or sedative drugs are used. As the type, combination of isopropyl antipyrin, acetaminophen, anhydrous caffeine, and isopropyl acetylurea is also used in Japan. In several countries such as UK and Germany, some triptans were approved as OTC. The problem with OTC access to triptan is overuse. Pharmacists should warn and advise the patient to use a triptan on less than 10 days per month. For natural herbal medicines, Kampo medicines are approved as OTC in Japan. Some of them would be used for the headache, for example, Kakkonto, Goshirto, and Goreisan. For the preparation of this talk, I will discuss with a community pharmacist in the case of the headache patient who visits pharmacy. One pharmacist pointed out the headaches are more common in women, so it is recommended to think about the balance of the hormone change for their scheduling, because headaches may vary depending on their menstrual cycle. Also recommended to pay attention to the weather change because its change the atmospheric pressure can affect to their headaches. Other pharmacists pointed out the patients who are buying ibuprofen OTC even though NSAIDs has been prescribed, and the other patient prescribed NSAIDs from multiple medical institutions. Most of them seems not aware of the relationship between headache and their lifestyle, for example, as possible trigger for the headaches like lights, smells, smoke, sleep, alcohol, and exercise. Pharmacists can support such a patient by asking their lifestyle and the timing and the strength of the headache attack to improve the lifestyle and reduce the number of the medications. And it is also pointed out if they are taking the medicine more than 10 days per month, medicine overuse headache would be suspected. As an example of the short-term interview of the headaches, screening the questionnaire forms are useful, such as 3-question headache screening, ID migraine screening, Midas instruments, HIT6, and HOUT index. It is valuable to collect the information with a limited number of the questions. And it is not might be a special method, but the other method can be used for the interview form, consisting with the following 7 questions with location, quality and quantity, timing and setting, factor, associated manifestations, and additionally lifestyle and drug history. For example, a patient has tightened pain at the back of the head, which continued from 1 year before and occurred once per month, and this time from today's afternoon, and getting long-term working PC strength and the evening, and weakened by the rest. In this case, it can be from the tension type headache. As the other patient claims severe headaches in head, catching a cold 3 days ago and getting worse from the last night. And it was with a simple training of the head and cough associated with high fever, chill, and nausea. In this case, headaches by the infection should be suspected. Headache diary can support the patient with recording their headache attacks, symptoms, and the treatment. It can help doctor to make a diagnosis, and pharmacists can use for the advice. Patients themselves can recognize triggers or warning signs, assess whether their acute and preventive medication is working, and show any patterns of attack. Regarding to the weather-associated headaches, what weather can be triggers such as change of the humidity and temperature, storms, extremely dry conditions, and dust environments. For the management of these kinds of headaches, research like a smartphone application to inform the weather forecast can be applicable to avoid such headaches in advance. As a possible medications, analgesics can be used, and compound medicines can be used as OTC in Japan, for example, with Goreisan. As take-home messages, several prescribed medicines and OTC are effective for the treatment, acute or prevention for the migraine and tension type headache. Approval of a recently developed triptan derivative and CGRP-related medicines increase the choice of the treatment of the headaches. Pharmacists can support a patient to reflect their lifestyle relating to the headache, which can lead to the improvement of their lifestyle and the reduction of the medications. Utilization of headache diary and the digital tool for the weather-associated headaches will be also effective to manage their headache. Medicine overuse headaches can be suspected when the patient take headache medication over 10 days for 3 months. Thank you for your kind attention.
Thank you also to Professor Sakuya for a very interesting presentation. And with this presentation, we finished the recorded participation of our speakers. And in the next two presentations, we'll have live speakers, well, the speakers will be live, just sharing their expertise. I would just like to remind you that if you have any question, you just write it down on the Q&A option, and please not on the chat box. And also, if you can stress out on those Q&As, which speaker you would like to have to take your questions just to be clarified. That way you easily can try to, for instance, answer, the speaker can actually answer the question, the answer to your question directly on the Q&A chat box, or if not, if the speaker would like to, she can actually pick up the question, just clarify it a bit later when you have the Q&A part. And with no further ado, move forward with the next speaker, Dr. Luminita Constantine. She holds a bachelor degree as a medical doctor from Bucharest, Romania, and certificate in medicine development from the King College London, UK, with over 25 years experience in pharmaceutical industry, working in multinational and multicultural companies, cross-functional global, so also a global citizen. She's a medical affairs professional at Sanofi, our kind supporter of this event, which promotes safer and appropriate drug use, enhance healthcare professional ability to make appropriate decisions in partnerships with patients and customers, and bringing the voice to the patient into the business innovation, medical insights, and also aiming to optimize experiences and outcomes for patients and healthcare professionals. Dr. Luminita, the floor is yours. Thank you.
Thank you very much for this introduction. Hello, good afternoon, good morning, and good evening, because it looks that the time zone, looking at the messages in chat, are from all over the world. I have had the opportunity to travel with FIP this week in all the regions, travel virtually, of course. And I was in Western Pacific, I was in Americas, I was everywhere, and now I'm in Europe, where I'm located. So let's look at the regional approaches to the headache self-care, leading non-prescription medicines and drugs. Looking at the worldwide, 50% of the people with headache are estimated to be primarily self-treated without contact to the healthcare professional other than pharmacist, of course. For European region, the figures drop down up to 40%, but they are compensated by higher proportion treated by specialists. I'm talking here 20% treated by neurologists and high level treated by primary care physician. We will look in the next slide at the prevalence of the headache disorders. And at the turn of the century, most of the world population lived in regions where prevalence of headache was unknown and its impact was poorly understood. Lifting the Burden, a non-profit organization in official relation with the World Health Organization, was working to scale this unknown burden. And via Global Burden of Headache, who was generated in 2018, they bring improvement of the data already created from the World Headache Atlas in 2011, from data coming from 101 countries. Based on a program of population-based studies, performing countries for all the world regions, they have demonstrated a high prevalence of headache disorders, including migraine, tension type headache, medication overuse headache, and their association with impaired quality of life, substantial loss of productivity, and high economic cost in every country survey. You will see here that for European regions, using the standardized methodology, they found broadly similar result. 1 year prevalence of all headache disorders was from 53 to 75%. Migraine was much narrower, up to 20%. Except with Moldova, this is the panel of the countries which enter in global burden of headache. Except of Moldova, the prevalence of PTH was consistently higher than the migraine, 31 up to 42%. And having in mind its likely impact, headache occurring more than 15 days per month was extraordinarily common, 5 up to 10%. I will still stay on that slide because I want to discuss a little bit about the European Union. This panel was analyzed separately by Eurolight project, which was a cross-sectional study with 8,000 sufferers, headache sufferers from all over European Union, and using a similar standardized methodology. And they found that the lifetime headache prevalence, it was more than 90%, 1 year prevalence 79%, figures you have them there, and almost equal proportion of migraine and TTH. Now let's look at the loss of the productive time. As might be expected with the next slide, headache disorders were generally associated with impaired quality of life across all countries, and also impact on productivity from paid work and from household work. And this was also reflected in the overall GDP impact. So societal impact was consequently high. The burden of indirect cost attributable mostly to this lost productivity was up to 1.5 in 2 countries where they measured this panel, up to 1.5 up to 1.8%. I would like to talk in the next slide about 21st century headache. What is 21st century headache? It's an expert consensus paper published this year, and experts agreed on the observation that headache now it's occurring earlier in life, it's attributed to this modern lifestyle. There are contributing factors mostly associated with changing lifestyle, such as stress, bad posture, physical inactivity, sleep disturbance, poor diet, and excess use of digital technology. So on top of this, COVID-19 pandemic pushed us to increase screen time, virtual meetings, and spend in social media. Also a high level of physiological stress, social isolation, sleep disturbances, and much more, each and any of us we are aware of. What is 21st century headache? It's not only pain anymore, it's pain plus negative impact on concentration. So pain plus missing concentration, missing attention, reduced capability of problem solving, reduced reasoning, perception, coordination, motivation. These are cognitive capabilities which are reduced when we are in pain. And also this creates a status which can be defined, and most of the sufferers and the headache, which are sufferers which were asked, this create a status of blur mind or impaired mental clarity. And 21st century headache, it is an impaired clarity and mental clarity in association with reduction in social interaction, absence from work, absence from slower at work, absence also we can be present at work but without having all capabilities and without being functional, reduced productivity at work, and lifestyle compromise. Going next, we will talk about the management of tension type headache and migraine. It was presented by Professor Godsby, but I would like to discuss a little bit more. Of course, patient education and trigger management, it's very important. But when we have some habits for 20, 30, 40 years in life, it's very difficult to change these habits. It's very important to understand why we are reacting and having headache. The next treatment recommended is symptomatic one. And of course, we are used to treat pain, to give analgesic. And overall, the main classes of drugs to treat headache disorders are analgesics, are antiemetics, are specific anti-migraine drugs, and prophylactic medication. I will look to the symptomatic treatment and analgesic mostly, and symptomatic treatment is required for mild to severe headache or when headache affects function. Of course, there are mentioned here non-pharmacological treatments can be used concurrently with pharmacological therapies or as a standalone therapy. Most prefer analgesic for the treatment of headache and migraine, according to the World Headache Atlas, are well known, are at hand, are NSAIDs, are paracetamol, and aspirin in the percentages you can see there. Overall, I can say that global analgesic preferred are same all over the world, and if aspirin and paracetamol are available in all regions to all income categories, and NSAIDs are available in 2/3 of the countries. In the next slide, we will look at the relation of the headache medication and COVID pandemic. Beside the obvious concern about limitations of virus spread and providing the best possible care to infected patients, a concomitant concern has arisen in view of a possible link between the use of certain drugs, such as renin-angiotensin system inhibitors and ibuprofen, and an increased risk of COVID-19 infection. This study shared this concern in relation to headache treatment and conclude that based on a current evidence, there is no reason to abandon the treatment of headache patients with RRS inhibitors or ibuprofen. And there is no convincing evidence that either RRS blockers or ibuprofen facilitate or worsen SARS-CoV-2 infection and in any type of patients, including headache patients. And going to the next slide, I would like to discuss about in fact, it's not a recent development. There are recent habits, let's say, and we will talk about self-management, COVID, and e-commerce. We found out very interesting that in quarter 2020, the pharmaceutical sales boosted by COVID pandemic, and high level of growth was expected to be only temporary, which happened due to consumer stockpiling of OTCs they prepare for the pandemic. Also, the channel they bought, because everybody was locked down, the channel which increased was the e-commerce, and online spending has risen during the lockdown and will likely catalyze a permanent switch to an online shopping for some consumers and patients, of course. And the growth was given by a higher dose of NSAIDs, new ingredients, fixed dose combination, among them many combinations containing analgesic plus caffeine, fast-acting products, smaller pack size, 4 pills, 8 pills compared with bigger pack size, and as I mentioned, combination where are growing in popularity. Although e-commerce of medicinal products has many benefits for patients and for pharmaceutical industry, it remains a concern not only for healthcare providers, for industry, but also for the regulatory authorities worldwide. Going to the next information, I would like to conclude that and I will take the quote Professor Godsby mentioned in his video, that primary headache disorders can often be well managed by the pharmacist. We realize, together with the expert consensus, that pharmacists play an integral role in pain management by assisting patients and prescriber with the selection of over-the-counter analgesic. A pharmacist may be the last healthcare professional who a patient sees before utilizing an OTC product. Patients often ask pharmacists for advice when selecting an OTC analgesic. Therefore, it is very important for the pharmacist to know what question to ask patients to help ensure that informed recommendations are made. I know it's easy to say and sometimes difficult when we have long lines of patients waiting for their drugs, but selecting the right advice for the right patient may be a step forward to contributing to a better treatment. These are the steps, and if we have time to assess the patient's characteristic and medical history, to explain the recommendation, to ensure that the patients understand the recommendation and what it was individualized. Just to conclude, I will take another quote that pharmacist Robert Barkin has said. We have a world of generic drugs, but no generic patients. Every patient requires specific consideration and an individualized recommendation. And for 21st century headache, this advice is still standing strong. Thank you very much for your attention and looking forward for your questions.
Thank you, Dr. Luminita, for the interesting presentation. I'm sure everyone's like thinking about some of the data you just presented. And then, of course, that COVID-19, it's a landmark when it comes to public health and other issues in our daily life. It definitely had an impact on pharmacies and community pharmacies work. It's interesting also to give the floor at the end of the next presentation on the Q&As to our colleagues who have been working on a daily basis, what they think about what you have just shown to all of us. And now we move forward with our last speaker, my dear friend, Dr. Charlotte Rossing. I've been knowing for many, many years. She kindly accepted the invitation to join us today. Charlotte, she's a pharmacist from Denmark. She was graduated from the University of Copenhagen, Faculty of Pharmaceutical Science in '98, and she holds a PhD degree in social pharmacy, focusing on the practice of pharmaceutical care in Denmark, a quantitative approach. Well, Charlotte has an extensive curricula. I have to stay here for a couple more minutes, I'm sure. Not only academic, but also on practice, investigation, research, and also in involvement in FIP with a lot of groups. And she's now in the steering committee of the special interest group on pharmacy practice research under the FIP umbrella. And she was one of the co-founders of the SIX, which actually is one of the most active SIX. And we are very much looking forward to hear what Charlotte has to say about this topic. Charlotte, thank you so much. The floor is yours.
Thank you very much, Louis, and thank you for inviting me. It's always a pleasure, as you know, and we go back a long way. Thank you, Louis, and thank you to FIP for giving me the opportunity to talk about this area that is close to heart, namely what can the community pharmacist do regarding headaches? What about self-management? How can we do that? If we move on to the overall, next slide, please. I'll just start with some stats. This is a recent investigation that we have seen in Denmark. And it was actually very much in line with what Luminita said just beforehand. The patients that are seen in the pharmacies are younger and younger. 75% have headaches before they are 15 and 40% before they are 7. What we see in Denmark is that 20% of the absence from work is related to headaches, which also makes this a huge societal problem. And 5% of the population in Denmark has headaches at a minimum once a week, which is also quite substantial. I'm sure if you cross the two data sets, you will see a big correlation there. 8 out of 10 have had a headache within the past year. So this is just the current stats, as you see. What I have done in my presentations, I've talked a little bit about the treatments, but I think the speakers before me has covered this very well. So instead, I will talk about, with the 4 different headache types, I will talk about the triggers. Because what I'm talking about today is how as pharmacists, when we meet the patient, how we can actually help the patient in their self-care and help them with a better treatment of their different headaches. I think one of the really important things is that you have to be aware of what are the triggers and talk to them about this. This is, of course, a preventive work, and it might actually end up with you not selling drugs, but that's the societal obligation you have as a community pharmacy as well. So I think that is good. So this is just the different headache types I will go through. If we start with the tension headache, the illustration shows how this is seen with the patient, and maybe this will inspire you to talk with the patient. So where is it situated? Usually just that question will open up the discussion about the headache. The triggers for tension headache is, of course, tension. It's the study that was referred just beforehand with the COVID data also support this. It's bad working positions, the jaws, you might be locked, or the neck. Your work position, you might have eye problems. So maybe you should maybe you haven't bought your glasses yet, or you should buy different glasses. And that might cause the tension. And then, of course, lack of rest and sleep, and stress and pressure. If you are to see this in a pharmacy, don't be afraid to ask. I like one of the end comments from my previous speaker, where she said, we have standardized drugs, but we have individual patients. So figure out what is the problem with this specific patient, help them with the medicines they ask for, but then also help them. A lot of the tension headaches can actually be helped by physiotherapy or something else, and just try to guide them in that direction so that in the longer run, they will have a higher quality of life. On the next slide, we move on to migraine. That we have also talked a lot about beforehand with the other speakers and the treatment, so I'll not go into this. But the triggers you should be alerted to with migraine, of course, you should see, is there a pattern here? So do I see the same patient coming into my pharmacy many times and ask for painkillers, for some of the normal analgesics, the simple analgesics, because it might be a migraine. If there's a system or a pattern in it, you should be curious about what this specific patient is actually experiencing. And as you can see, this is usually located in one of the head, but also it can go down over the eye. And the triggers for migraine might be stress. It might be depression or anxiety. Again, bad sleeping patterns. What is unique about the next two is that foods might also trigger this. We know this from a lot of experience and studies, but also menstruation. So for women, when they have their menstruation, they might also have this specific migraine coming into the scene. On the next slide, we have the treatment. I will not go into this, but if we can just take the next, yes. What is important is that if the combination analgesics should only be taken at a maximum of 9 days a month to avoid overconsumption headaches. And I'll get back to that. Because one of the problems with migraine, I'm sure if you have met people with migraine, it can be very hard for a patient to experience this. And therefore they are in a risk of overuse headaches that you should, of course, see if you could spot. If we move to the next one, this is Horton Headache, also called the cluster headaches, which comes in periods of time, very massive, then go away and come back. If we move to the next one, it is overconsumption headaches, where you see the treatment, basically the treatment for overconsumption headaches is stop the overconsumption. So if you see people coming into your pharmacy asking for the same medicines over and over again because of their headache, maybe you should just start by asking, what are you using this medicine for? Because if they ask for painkillers, they might not necessarily say that it's a headache they need to be treated for. So stop overconsumption of analgesics and migraine. So you should look at those two. If they eat too much of that medicines, be aware. Deprescribing if it's prescription medicine, And also it's important there in Denmark, I would have to talk to a general practitioner to be able to do that, but that's not the same in every country. But just be aware that there's also, if you are walking into a deprescribing area, you should also talk about abstinence treatment. And then, of course, all the education and support you can do from within the pharmacy. You have a huge role in just informing about these different initiatives. On the next slide, I've shown some of I found some new studies. So what are the services? If we are to look at services, that's part of what my research has been about for the past 20 plus years. So of course, I'm interested in, one thing is the everyday dialogue within the pharmacy, but can the pharmacists do more? And I found just a few studies. I'm sure there's more out there. The first one is a German study with migraine patients that shows that if you do targeted service towards these, you can improve their mental health and their self-efficacy. Next study shows that's a Maltese study where 2 protocols were developed and evaluated, and it was a very significant result that if they use these protocols, the professionals felt a higher sense of self-efficacy regarding the counseling of the patients, and you also saw better results for the Maltese patients. The next study is from one of my neighbor countries, namely from Norway, where they've also done a campaign regarding how pharmacy staff is feel self-efficacy in their counseling areas, and they did a lot of training in Norway, which showed positive. And the last one I've brought is from the UK, where they have these minor ailment schemes. And one of the minor ailment schemes is community pharmacy-based headache management, which proves very useful and improves quality of life for the patients included. Thank you very much.
Thank you so much, Charlotte, for the inspiring presentation with a connection here, a stronger connection to the daily life of community pharmacists. And thank you for sharing this literature review, which is very useful for those who want to know more about what community pharmacists do related to this topic. You are actually, roughly, we're running a little bit out of time, but I'd just like to emphasize a couple of information that we had from our 4 speakers. With Professor Peter Goodsby, we mentioned, or we learned a little bit about the doctor and non-doctor treated headache on the population, and the second one is like roughly 50%. So there's an extensive area to work for community pharmacists. You spoke also about the medication overuse headache and the management of tension type headaches and migraine, the most common. So that there were a lot of information and facts. So if you have the time to, and that has been mentioned previously, you can go through this webinar, since it will be available to FIP members on the FIP website. With Professor Takuya, we went through the international classification of headache disorders, type 1, 2, and 3, and also the medication of the same headaches and the prophylaxis, and also on the acute crisis. And also we covered a little bit what we can do when headache patients visit the pharmacy. You also shared some examples of screening on questionnaires for headache patients, and also mentioned a lot about the weather-associated headaches, the so-called barometric pressure headaches, and the importance of using headache diaries and digital tools to help on the diagnostics and the management. With Dr. Luminita, we focus on the prevalence of headache disorders and the impact on the loss of productivity in the population. We had some insights as well on 21st century headaches, the fact that there's a huge impact on social interaction, since it is reduce the increase of absence from work, amongst other negative impacts on our daily life, and also focus on the headache medication and the COVID-19 pandemic. If you're a community pharmacist, I think it happened worldwide. I've been able to chat with other colleagues. The consumption of meds has increased quite a bit because of the pandemic on the first wave, because people were afraid that there probably could be some shortage of medicines, and later on, because you want to have an arsenal with them just to deal something that could happen with their health. And also Dr. Luminita also focused on the pharmacist perspective on OTC analgesia. And lastly, but not least, of course not, Charlotte mentioned a lot of facts about headaches, very practical approach. There was a focus on the triggers, treatment both for headaches and for migraine. So a lot of information for community pharmacists who actually deal with patients, some information and tools to help on a daily basis, and also share some literature about services related with healthcare, health with headaches and migraines management. So we have a couple of questions here. We have a question from Ms. Rossing. For those who constantly suffer migraines caused by stress and those over the 10-10 period take medicines, what should their mode of treatment be? And then I will have another one taken from there. Still waiting. Dr. Luminita is answering some of them, I presume.
Yes, we are
Yes.
answering sometimes.
Okay, so thank you for that. Thank you for that.
Out of
So,
time.
so I'll give the floor to Charlotte. I think so. Again, for those who constantly suffer migraines, headaches caused by stress, and thus over the 10-day period take medicine, what should their mode of treatment be?
Yes, and I was just typing another question regarding the overuse and the migraine, and it's actually quite similar. I think unfortunately you would see this in the pharmacy. Mm-hmm. So in a perfect world you would catch this before it actually plays out. But if you reach the point where this is playing out, what I would do in Denmark then is that I would go together with the general practitioner, because in Denmark they have the responsibility of the prescription of migraine medicines. And then I would do a plan for deprescribing the medicines and see how much is actually needed for the migraine. Because you might have needed a certain thing in the beginning, but then later on you might not need as much. And of course, if it's stress, if it's one of the triggers, maybe you should start talking with them and then put them back to the general practitioner and maybe help them get some different kind of help. Yeah.
Okay. Thank you so much for feedback. There's also some other question that was sent directly, and it's for Dr. Luminita, focusing on the role of fixed dose caffeine in combination with other analgesics. So I think it was one of those hot questions, and I'm sure that it's spread all over the world, the question, isn't it?
Yes, indeed. It's a high interest on the fixed dose combination, and especially on the analgesic plus caffeine. There are caffeinated headache medication, either alone or in combination with other treatments, are widely used by patients with headache. And compare with analgesic medication alone, combination of caffeine with analgesic, including acetaminophen, aspirin, and ibuprofen, showed significantly improved efficacy in the treatment of patients with tension type headache or migraine, with favorable tolerability in the vast majority of patients. I want just to raise up a point that fixed dose combination with caffeine, there is an analysis behind the level, the optimum level of caffeine to be connected with the analgesic. There is a range in a Cochrane meta-analysis between 60-150 milligrams, which is considered per tablet optimum. And be mindful to investigate, and the caffeine in a coffee we are drinking, it's not the same with the caffeine synthesized in a compound. Also, our way we are responding to the caffeine, it's quite different from a person to another. And it's very important to understand what are their habits, what are before taking a pill, and to know about this caffeine role as a co-analgesic in a fixed dose combination.
Thank you so much for the feedback. Some of the questions have been put on Q&A as have already been answered. I'm very conscious of the time, because we are all very busy people and you're actually touching the end of our presentation. So I'll just like to share some extra information. We had roughly 220 plus participants on this event. I've just shared a few moments ago a sum up of all the presentations, but remind you that will be available online on the FIP website in the next couple of days. Remind as well, for those who have joined us a bit later, that certificates of attendance will also be sent to all participants. And I would like to thank again our speakers, the ones who have recorded their videos, and the two ladies have been joining me here for this hour in this afternoon. Remind as well that on September 25th, we had the World Pharmacist Day. So just take a few moments and to create a graphic and add your voice. So you have the topic, you have the link here. So it's a challenge I'll like to address to all our colleagues, and to remind you that this World Pharmacist Day is an opportunity for our profession to make our vital role in improving health known in every corner of the world. Thank you so much for your attention. Thank you so much for the speakers, and also to the Secretariat of FIP, who has kindly taken care of all of this, of all the logistics. And I'm very much looking forward to see some of you, or at least part of you, but if all, even better, on the next webinar and event of FIP. Thank you so much.